Assistant Professor. Welcome to my Case Connections video. So today I'm going to be talking about case scenario 3 and 4. So first I'm going to start with my discussion and response to case scenario 3. So after further investigation, the underlying biomedical basis for this patient's symptoms are suggestive of diabetes mellitus, more specifically type 1. Statistically, type 1 is more commonly seen in infants and toddlers than type 2. However, type 2 is on the rise in young children, though most cases are correlated with being overweight or obese. Furthermore, drowsiness, frequent thirst, known as polydipsia, frequent urination, known as polyuria, are the patient's responses to elevated glucose levels circulating in the body. Since there is a large quantity of glucose trying to filter through the kidneys, there is only a maximum amount that can be absorbed by the kidneys at a given time. Unfortunately, with diabetes, the amount exceeds the renal absorption threshold, meaning there is not enough transporter molecules to attach and uptake all of the glucose. The result of this is that the glucose ends up being excreted into the urine, known as glucoseuria. Consequently, there is excess glucose. That means there will be excess water following, since this entire process works by osmosis. The great loss of water into the urine, known as osmotic diuresis, makes the body volume depleted to the point where the individual becomes very dehydrated and has an increase in thirst. As previously alluded to, in regards to the individual's current condition, I would predict that the fasted blood glucose levels would be above normal range. The reason why is because when considering the serum insulin levels before and after glucose administration, the insulin in the blood still appears to be extremely low. This information leads me to believe that the patient is very hyperglycemic due to inadequate insulin hormone release. Also, there would be multiple regulatory enzymes activated in this individual's current unstable state. With a lack of insulin available, CAMP cannot be cleaved and it ends up accumulating in the body. The increase activates protein kinase, PKA, and this forms an entire cascade. One of the target proteins controlled by CAMP and PKA, which is known as protein kinase A, is phosphofructokinase 2 and fructose 2,6 biphosphatase. These two enzymes are increased and they end up lowering fructose 2,6 biphosphate, which initiates glucogenesis and inhibits glycolysis. In addition, this cascade activates the hormone-sensitive lipase, breaking down triacylglycerol into free fatty acids and glycerol. In this case study, there are just a couple out of the various different enzymes that are activated in diabetes mellitus. Okay, so I'm going to review my response to case scenario 4. So, after thoroughly researching each condition, I believe that the accurate diagnosis for this patient is glycose storage disease. I will first explain my rationale and reasoning for this diagnosis. So, glycose storage disease is an inherited disorder caused by an accumulation of glycogen in the tissues and organs, which is a result of a lack of the glucose 6 phosphatase enzyme. Normally, after a meal, the body stores the extra glucose as glycogen in the liver and muscle tissues. During the fasting state, glucose levels begin to drop in the body, so then stored glycogen comes into play, which then should be broken down by G6P, which is the glucose 6 phosphatase enzyme, and released as glucose to maintain blood sugar levels in between meals. Since this enzyme is unable to perform its function of conversion, the individual becomes extremely hypoglycemic and the glycogen builds up to dangerous levels in the liver, hence the jittery spells that the individual was experiencing. This disease commonly manifests in infants around the age of 3 months and can occur equally in males and females. The liver is negatively affected by this increase in storage and can become significantly enlarged. This is known as hepatomegaly. Since the body has inadequate glucose to make energy, lactic acid begins to build up as the secondary energy source. Furthermore, epinephrine is used to initiate release of glucose from the liver. However, that process cannot be initiated since it also relies on G6P enzyme to take place. All of these findings confirm that the child is suffering from this disease. Now I will discuss why the other answer choices are incorrect. Firstly, glucose 6-phosphate dehydrogenase, which is known as G6PD deficiency, sounds similar to the previous enzyme, but plays a completely different role in the body. It is used inside the red blood cells to help prevent oxidative damage to hemoglobin and other structures. When this enzyme is defective, it cannot properly break down the red blood cell, causing premature hemolysis. This individual presents with different clinical manifestations, such as enlarged spleen, which is splenomegaly, yellow skin and eyes, known as jaundice, fast heart rate, tachycardia, fast respiratory rate, tachypneic or tachypnea, and blood levels will also reveal that the individual is anemic. Also, it is almost exclusively seen in the male population, being that it is an X-linked disorder. None of these signs or symptoms are linked to the case scenario. In addition, galactosemia is when galactose cannot be converted into glucose. Usually after consumption of lactose, the body breaks down galactose into glucose so it can be used as energy. Since the enzyme is incapable of its job due to the malfunction of GALT, the body has a buildup of the galactose. I forgot to mention, the only way galactose can transform is by the help of galactose 1-phosphate transferase, so it's GALT enzyme. So, because this enzyme is malfunctioned, the body ends up building up in galactose. So within a couple of days after birth, the infant begins to show health effects. The infant will start having episodes of severe diarrhea, vomiting immediately following the consumption of milk products containing lactose, for example, breast milk and/or formula. They quickly begin to lose weight and are unable to feed efficiently. Later effects can be hypoglycemia, high ammonia levels, and enlarged liver. Lastly, hereditary fructose intolerance is when a person cannot digest the sugar fructose. This condition begins in infancy when the infant is first introduced to fruits or fruit-containing products. The infant may experience nausea, vomiting, diarrhea, abdominal pain, bloating, and low blood sugar. Despite there being many close similarities in the presentation of each condition I described above, I am certain that based on the evidence I have found, and more specifically the main context clue of how the infant failed to respond to administration of epinephrine and formed lactic acid, has convinced me to lean towards glycogen storage disease as the culprit. So thank you everybody. I hope you enjoyed the video and I look forward to listening and learning to what you guys have to say about these case scenarios. Bye!